Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the data platform that accelerates innovation in healthcare. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. Accelerate innovation, digital transformation, and your success with population health, customer relationship management, and value-based care with Innovaccer. Visit us online at innovaccer.com.
Hello, everyone. Welcome to the Innovation Accelerator's Future of Healthcare podcast. I'm your host, Steve Ambrose. One of the most important topics in healthcare today is the adoption of value-based care. Now, the framework and models have been heavily tied into primary care, and primary care, depending on the payer, accounts for only 4 to 8% of all healthcare spending in the U.S. every year. On today's show, we'll be talking with value engineering expert Dr. Sanjay Seth on the future adoption of value-based models specific to specialty care. We'll dive into a discussion on opportunities, emerging trends and top challenges, as well as what he sees as the most important success factors and best practices for this shift in value-based care adoption. Dr. Seth, it's a pleasure to have you on the show. Thanks for making the time to be with us.
Thank you, Steve, and looking forward to this conversation. Again, the world is changing so quickly, so I'm glad that we are having a conversation about specialty care and the costs associated with the delivery of those services. It's really important for all of us to understand if we have to make a shift in cost, we need to address both primary and specialty care.
And before we get started, please share a little bit more about your current roles and responsibilities, and speak a little bit, if you could as well, about your career journey that brought you to where you are today.
Sure. So going back into the time capsule that I have, started off by becoming a physician, but fairly quickly realized that it was more a business than it was clinical care that made it possible to be sustainable. So I went into the business side of medicine, got a master's, and came out into the healthcare world as into the turnaround business, unfortunately or fortunately. And we were doing hospital turnaround of distressed hospitals, and I didn't really have to travel too far from the Northeast because there are enough institutions failing in each of those, the tri-state area. Did that for about 14 years. And that led me into doing something similar for providers, and did that for about 8 years. And then the Affordable Care Act was announced. And when you look at it, when I read the regulations, it was clear where CMS was moving towards value-based care. And so I transitioned into creating accountable care organizations of the providers that had an affiliation with me. That brought me to understanding that you needed technology and data to help manage and transform the practices. And so I got involved in the data part, and that's eventually ended up at Innovaccer as one of the leading data platforms for value-based care, population health. And so having a single source of truth to rely on for practice transformation and to attempt to correct provider behavior that will eventually influence patient behavior is how I ended up at Innovaccer. And within Innovaccer, one of the challenges that we face as a technology platform is, if things go right, technology is lauded. If things don't go right, technology is at fault. So to help organization understand and appreciate the value that good technology brings to their success, Innovaccer created a division within itself called value engineering. And so I lead the value engineering customer success division within Innovaccer, and that's my current role.
Thanks for that, Dr. Seth. Let's jump right into this discussion. In shifting the provider's foundational model from fee-for-service to value-based care, Now, one would think that specialty providers that, make up such a large part of care encounters and certainly healthcare costs, people would have thought that specialty providers would have been key to include from the beginning. So why haven't they been?
Well, if you go look back a little bit into history, the government felt that if they transitioned the burden of effective cost control to other than from themselves to other entities, they thought they would be successful. So the first foray, I think, that CMS tried was to shift that burden or responsibility or accountability, which is now a better word, to the payers. So the insurance companies took over that, but they failed to realize that the insurance industry is driven by economics, and it's part of Wall Street. So the incentive to drive down cost was not from improving care or improving outcomes, but from cutting corners to save money. And I think they quickly realized that the insurance companies imposing themselves on utilization and through approvals and prior authorizations was not the way for the future. So they figured, who should we give this responsibility or shift this responsibility to? And they felt that the primary care provider that controls the patient the best would be the ideal place to start. And I think that's what the bright minds there thought. And I think it was the right approach, except changing provider behavior that drives the rest of the care other than what they do themselves was left out. And I think now they're beginning to realize that, wait, you can't do that just with PCPs. You have to have the specialists involved. And we've seen that evolution come about at CMS, where they're doing bundling programs for certain disease states, certain procedures like joint replacements and kidney disease. So I think they've realized that they need to have similar shift in accountability to the specialists as well. But that's a topic we can get into more, because I think it's not as easy as a shift as it was for primary care.
Well, when you talk about specialty providers and value-based care, what do the programs look like today for specialty providers, and how do they differ a little bit in design and integration as maybe value-based care would be in place with primary care?
If you look at the models that CMS has created, or even the payers are beginning to adopt, it's all about economics. And I have a saying: the sooner we think about medicine as a business, maybe it'll help us all. But the economics need to drive all of this, and the shared savings, upside downside risk, is something that was a large enough motivation for a lot of physician or hospital-based organizations to move towards value-based care. I think the relatively proportionate levels of shared savings that occur at primary care can't be the same things that motivate or influence behavior at the specialty level. Because if you take the average compensation income at a PCP level in the country, it's around $220,000, $240,000 per year. So if you give them a bonus of $20,000 to $50,000, you're talking 10 to 20% bonuses. That's significant for a primary care provider. If you talk about $20,000 to $40,000 incentive to an orthopedic or a neurology or an oncologist, it's really a drop in the bucket in their compensation. So I think that's the next challenge we are facing, is that using similar economic drivers doesn't quite work with specialty care as it would work with primary care.
This is a question that I'm really had thought a little bit about before this interview. And you mentioned looking at things like a business in healthcare. So why would provider organizations who have, to be clear, to their benefit, kept specialty care providers largely within the fee-for-service model, why would they want to move that financially lucrative segment of services into value-based care?
I think the common misperception is that moving from fee-for-service to value-based care eliminates fee-for-service. It does not. A value-based care adds to the current fee schedules. So we are today in that stage. So we shouldn't think of it as moving away. It's just saying there's an added incentive on top of your current revenue stream or through fee-for-service, that there's an opportunity to make more if the outcomes, desired outcomes are met or improved upon. So it's a little bit of a misnomer that moving means reduced income, moving means reduced reimbursement. It isn't. It's really you're adding quote unquote bonus payments to the already existing fee schedule. So it's really an enhanced compensation model today.
Well, I mean, it's interesting. I know, and we're going to get into this in the interview. There certainly have been bundling programs around joint replacement and around, I believe certain cancers, but they haven't been widely. There were some specialists that jumped into that. There may certainly still be, but there were some that jumped back out, and that's really why I'm asking is, if it's so lucrative and potentially lucrative, why aren't all specialists jumping into it?
So let's use those two examples of joint replacement. Joint replacement bundle, it was for lower limbs and then it became for all joints. Hip and knees were the first targets, but it became mandatory at the hospital level. So CMS identified the institutions that were doing a significant number of these procedures and made it mandatory. That's usually a mental barrier for everybody. When you're forced to do something, they rethink everything. The second part of that arrangement that CMS started off was a retrospective review. So you would have a patient show up in the emergency room or get admitted to have a joint replacement, went through surgery, went through rehab, and there were a whole bunch of circumstances where they would be excluded from the bundle. Maybe they had too long a length of stay in a rehab facility. They didn't get enough physical therapy, things like that. And so you didn't know, or the provider and the institution had no idea if this patient would be included in the final reconciliation or not. And I think that was a design flaw. So I think that happened with the joint replacement bundle. With oncology, with the current state of development with oncology treatment and management, new drugs are coming into the formularies every day. And as they come in, they are frightfully expensive. And so CMS, in their wisdom of designing the OCM model, would let a new drug cost get adjusted through a factoring process for a certain limited period of time. So if a drug A was the best solution for breast cancer, they wanted you to move more patients into drug A because that was the ideal or current standard of practice. But from January through June, and then on June 30th, that drug was no longer qualified to be factored, their cost to be factored ongoing. So now you have patients and providers saying, oh yeah, this is giving me better results for a particular patient. But you know what? Now I have to include 100% of the drug cost into my financial reconciliation before I would get a subsidy of 15%. And I think, again, a design flaw. And that changed how the providers thought of treating patients, that while they were successful using a particular drug, now they're not getting the benefit of moving a patient into that drug regime, but their costs have suddenly gone up by 15%. So whatever shared savings I had while the patient was on that drug, it was good. Now that drug no longer qualifies, and CMS calls that novel therapies. So novel therapies had a finite timeline, and I think that was a design flaw. Now they have a newer model of the oncology care program, OCM, and that has its own limitations. So initially, they incentivize the provider by saying, hey, we know you have to do non-reimbursable activities or services for a patient to get them to improve social issues, transportation. And for that, we will give you an additional $160 per patient per month while they were on the chemo program. Now, the new model dropped that, I think, from $160 to $70. So, where the practices saw a benefit of enrolling more patients into the program, getting them qualified, putting them on the right regimes, monitoring their quality and satisfaction, which are all included in the metrics of performance, all of a sudden didn't see the incentive to be large enough. And think about an oncologist who makes $1 million. You give them $4,000, $10,000 as an incentive. It's really not an incentive. It's actually a deterrent because now you're asking for more work for really very little money. And they'd rather get new tires or a Tesla.
You brought up some of the models in your last answer there, and I'd like to ask, maybe if you can go over some of, maybe just a few, if you could, Doctor, about some of the emerging value-based care models that are out there for specialty care providers today.
So we start with the biggest one that CMS has rolled out, which is end-stage renal disease. The original reimbursement for end-stage renal disease has changed over the last couple of years. So now more payers and providers like DaVita, Fresenius, and US Renal were looking to shed some of these patients off their program, but now they're willing to keep them on. And I think that's in my opinion, that's a well-designed program. It's got the right incentives. It's got the right surroundings in terms of quality of care, interventions, and moving patients away from dialysis into transplant. I think those are the right designs to the model, and we are beginning to see a better and better compliance and participation in the end-stage renal disease model. I mean, just as a comparison, the end-stage renal disease average cost per year in the US is somewhere around $80,000. Compared to a non end stage renal disease patient is somewhere between $9,000 and $11,000 per year. So it's a huge difference in cost. So I think that we are beginning to see more participation, more enrollment in those models. The newest that I'm seeing, and as we all know, that cardiology, oncology, endocrinology are the next largest use subspecialties or specialties. So we're beginning to see some emergence of disease bundles, and CMS has had congestive heart failure and pneumonia and others as part of a program. But again, the design flaws are that it's a retrospective qualifier, and that makes it really hard to manage. But I'm beginning to see peers coming into some form of bundling a disease state with a prospective payment or a cap in payment that gives a target or a benchmark for the specialist to perform against in terms of cost.
Yeah, in your answers, two words keep sticking out to me, or maybe one grouping of words, and that is models and design flaws. And it sounds like to me, and I'd love to get your thoughts on this, it sounds like that it may not in many cases be an unwillingness of specialists to get into value-based care or certain models, but that once they get in, there are these hurdles that come up that might be unexpected. There might be some moving pieces, like you talked about drug costs and the like. Maybe you can just address that a little bit broadly. Your thoughts on how the models are improving, and in particular, where you see design improvement as wholly necessary into the success of these programs.
So, CMS or people like Innovaccer, we have all the data possible that could be assembled in one place. you can't look at saying, okay, I'm just going to manage patients in congestive heart failure. Well, the American College of Cardiology or Medicine have these standard protocols that they expect their providers to adhere to and help define quality of care and standard of practice. And if you don't take all the elements that go into that disease management process and include it in the model design, you're going to see these issues come up. For example, how many stress tests or nuclear studies or pacemaker implants do I need to do for which patients to manage them based on some national standard? And if you don't look at that data in advance, a single procedure like a pacemaker or an electrophysiology study would throw off the cost curve dramatically and quickly. It'll be one or two events that will throw the cost curve off. And now you're implying that the doctor should do a fewer of those studies to manage the patient, and which may not be clinically appropriate in their mind. And we have to take that bias into play. We also have to take a view of the training of these providers over time. And somebody who's graduated 15 years ago has a different perspective on management than somebody who's coming out of school today. And so you have to account for those biases and habits and try and influence those changes one at a time, not try to do it globally all at the same time. So I think that's what I mean by design and modeling exercises that need to be done.
Right. You talk about the models, Dr. Seth, and do specialists, because knowing that CMMI wants to, Medicare, Medicaid Innovation Centers wants to have everybody who's on Medicare and Medicaid in some sort of a value type touch point or value type program by 2030. That's the big initiative from CMMI, and that's the year they're looking to. You talk about the new models for specialists in value-based care. Do the specialists, or will the specialists, have to use these models directly? Or are there other ways that they can get involved with value-based care and still be a part of the transition and change from fee-for-service without directly being in these models?
I think that's a very good question. Think about the population of a provider or their patient population. 30% may be directly reimbursed by CMS. The other 60% are in some payer's bucket. If I have to treat patients coming from Blue Cross one way, coming from Humana another way, coming from Medicare fee-for-service a third way, I cannot practice what I would consider to be the best protocol across all these populations, because the model design for Blue Cross is slightly different than it is for Humana, than it is for United, than it is from CMMI. And that creates a huge operational nightmare in the practice. So while CMS is encouraging payers to participate in these value-based design programs, I don't think they've put enough details, specifications for all of them to enforce or follow. So I'm ending up as a practitioner looking at doing different things for different patient cohorts, and that makes my life very hard or miserable. And so I'm going to shy away and not accept it. Because again, the requirements of value-based come with other needs, other services that are required, paying attention to quality, paying attention to utilization, looking at supporting the family, looking at social determinants of health. And all of those are unreimbursable encounters, events, and it becomes too much of a burden. So I think that there has to be a little bit of better coordination so that my entire population, patient population, I can treat the same way. I do have another saying that says the best business for medicine is good medicine, but it's a relative term, right? What is good medicine? It means so much. It varies between providers, regions, states, schools. So I think fundamentally we need to be a little more inclusive and less sort of partitioning. And I don't have a off the top of my head solution for that problem, but CMMI is beginning to think like that. We can see that in their program development. Take something like PACE together. I mean, I think that's been one of their most successful programs, where it's uniformly applied to all patients that are eligible for that. But at the same time, not every patient is eligible for being included in that PACE program. So hospitals and physicians end up having to partition their brain to say, oh, patient A, B, and C, I'm going to treat one way, and patients D, E, and F are left on their own. I mean, or I'm being a little facetious about it, but yeah. And when I have to do that, I have to operate my staff, my front desk, my appointment system, my triage. Everybody has to think differently. And now they have to look at the patient and say, how do I have to treat this patient? What do I have to focus on? That's not an easy operational implementation program. So I think that's where the challenge is today.
Dr. Seth, you touched on this before. When you look at all the different specialist types that are out there today in healthcare, who do you see as or which of them do you see, I should say, as the first movers in the transition to value, and why?
I see two specialists that should be in that 1 and 2 category. The nephrologists, because of what our cost of end-stage renal disease and disability is actually having an impact, not only on cost, but on the economics and the social structure, and cardiology. Those are the two, and they are for different reasons. Cardiology and nephrology have one common thing, that it's all managed. They're all managed using data. They measure certain metrics, whether it's in the blood or in the performance of their heart, that drives the care. And that's using data to manage patients. And I think that's why I think those two specialists have taken the lead in terms of creating a program or a model for value-based, which is easier and better. And again, as physicians, we've always been used to evidence-based medicine. That is, we react not on assumptions, but actually on the data that comes either from the lab or from procedures. And I think that's why those two specialists, I feel, have led the charge to do more value-based discussions with the payers and CMS. More data is available. It's easier to help them manage using data than somebody who is an endocrinologist, perhaps, and who is looking at far more number of data points that sometimes may not be available as structured data. So I think that's where it is.
If you were going to lay out, in your opinion, the top 2 or 3 common challenges to specialists that they would encounter when they're moving from fee-for-service to value-based care, what would those top 2 or 3 challenges be?
I think it's data. Getting the data to support a particular module or a protocol is the hardest part. And we are unfortunately still in a hybrid situation in the country in terms of having data available as structured data. Some labs today still send PDFs, and so you don't know what the value is until you read it, and that makes it hard to put it into a data architecture, although there are lots of new technologies that are helping do that, but it's still a deficit. Gathering the data from the equipment procedures is still an art rather than a science. And I think that data aggregation to bring all this information together in one place to help drive good decision making is still very manual. I think those are the two specialists, but they have the same issue that data is not consistent, accurate, and digitally available.
And you would look at data interoperability and maybe activating data as one of those best practices that needs to be better managed and better adopted.
Yeah. So while today I know that the patient had a pacemaker put in, I have no idea what were the results of that pacemaker on their rhythm or their the efficiency of their heart muscle. All of that is still needs to be read and viewed and manually computed, and that's really not a way to help become more efficient and productive.
Yeah, we chat a little bit here and you've mentioned it in some of your answers about data and analytics and certainly for primary care providers and in value-based care, data and analytics have been essential to inform, decision making and drive better outcomes. So when we shift this over to specialists, I want to go ahead and just ask you a few questions. First, what are some of the main metrics or measures that specialists should be using and monitoring and maybe moving the needle on?
I think, again, depends on the specialty. Endocrinology, nephrology is all lab, blood work related. Cardiology, gastroenterology are all procedure driven data analytics. What did the rhythm look like? How many times a week they ended up in arrhythmias, and how many times they had heart blocks, and what happened when I last did a nuclear scan, things like that. Those are the data points that need to come in, and now we have AI coming into the picture, machine learning. We should be able to look at trends. We should be look at patterns. But if you don't have that data, you can't do any of that stuff to help behavior change. And so I think those are those data points in analytics around data points that need to come in. Just looking at the information as pure raw data is not actionable. You got to convert that into actionable data, and that means you're thinking of things like pattern recognitions and trend lines.
And you're looking in terms of making that data actionable. You see that as in terms of specialists demonstrating value of their services. Do you see that as integral to that?
Yeah, because how do we teach a cardiologist who is out of range in terms of number of times their patient with congestive heart failure has a nuclear scan done, and they believe that they should do one every 3 months or every 6 months or at a particular point in the patient's lifespan that is sort of displaying a particular symptom or sign, and say, listen, that's not having the right impact. You're doing the study, it's not giving you enough information to make a change in treatment, so why are you doing the study? And that's a retrospective look back at the physician's practice pattern to say, I think, instead of repeating it every 3 months, it doesn't make sense. You should do it every 6 months. That kind of conversation, that behavior change will only come if you show them back their own data. And it won't come just because a study said so. Because every physician believes that their patient is not the same as their neighbors. So that feedback loop to affect behavior change needs to be at the provider level. And so if you're not capturing any of that data to give them that feedback, then they're not changing behavior. Cost can't be the only driver. It has to be quality of care, because we all as physicians think altruistically about ourselves and say we are there to improve the life of the patient, so you have to address both.
Yeah, it's interesting. So many times when we get into these models, value-based care models, that, the data, as you said, is so important to that for succeeding in it, and also obviously for outcomes and quality. And a lot of times it seems that, it's the exchange between the provider and the payer. That, here's the data, we're substantiating it, you're going to pay us for that, and, the back and forth, and we're going to monitor it. But you brought up a really interesting point here that I just wanted to touch on, and that is, that value can also be, and data within supporting value can also be bridged over into patient experience and patient engagement, things that necessarily aren't right just between the provider and the payer, which I thought's kind of interesting.
Absolutely. I think that if you're doing things for yourself versus doing things for your patient, it's a whole different perspective. It shouldn't become a CYA situation that I'm avoiding malpractice, so I'm going to do this, but it should be what's best for the patient. And unless you measure the quality of life changes for the patient, how do you know you're really affecting change for them? You might be doing all the right things, but you're creating misery for the patient.
Interesting.
Oncology, nephrology all come towards, even some of cardiology comes towards end of life care, which is a huge another topic. But we spend disproportionate amount towards the last months and weeks of life than we do for the rest of the lifespan. But so end of life care, what should take priority? CYA for my malpractice, or patient's quality and family's quality of life? And I think that's a little bit of a paradigm shift for all of us, that we tend to still stick to our tradition of, hey, we are the doctor, we are going to manage and treat the patient, and the patient's experience, family's experience, and is secondary. And I think we need to change that. And it's more towards the end of life than it is necessarily towards the early stages of any disease process. But I think that thinking should be reversed overall.
Just staying on that theme of patients, Dr. Seth, what role do you see patients playing in the transition of specialists into value-based care?
I think the biggest behavior change we need to see on the patient side is self-referrals. So long as we have health plans with unlimited access, patients are always going to say, you know what? Oh, my cousin said this was a cardiology issue, I should go and see a cardiologist. Or this is a cardiology issue, what does my PCP know? And I think that while that is available as a thought process to patients, that behavior is going to be hard to change. And I think that ChatGPT or Google has not made that any easier, because in my opinion, Dr. Google and Dr. Chat are primary consultants, and then my physician is, a secondary, or is actually not. I'm going to go there with questions. You see advertisements in TV saying, ask your doctor about this medication for psoriasis, and I'm going to go and ask my doctor for that. So I think patient behavior requires more than just education and talking. It also requires this ability to self-refer and ability to succumb to advertisements, personal or on TV and social media, which is now becoming a huge part of any pharmaceuticals business go-to-market strategy. So, go get your shingles shot because it's free. Well, it's really not free, but we want you to get a shingles shot. Everybody is now jumping for shingles when we should try and make that a judicious use. And we've seen that when it happened with COVID. Everybody is clamoring to get COVID vaccinations, and we ran short, and we couldn't vaccinate the right people at the right time. And it happens all the time for any new medication. Look at the management of diabetics using Ozempic and Trudicity and all of those. They're being the unintended or the off-label use of weight loss is drawing the medications away from the people who really need it most. It happened with the early stages of COVID, where medications were just not made available to the right patients with cardiac problems because somebody said that this medication is good to prevent COVID. So how do you change that? And I think as a community, we need to make sure that our use of social media to disseminate information is done judiciously, not indiscriminately. I mean, you can talk to my kids and they'll know at least 4 of the new oncology meds because it's on all the social media and on TV all the time.
As you're answering that last question, Dr. Seth, it comes to mind that this idea of value, certainly it's in value-based care. You think value, you think quality, but it appears too that value is so important as to how people value health as a whole. Will people want to make their health a priority? Do you think there has been a heavy presumption around that from the healthcare side, that because it's important to healthcare providers, it's just naturally going to be important to everybody? And with that said, where do you see data maybe playing a role in helping patients view their own health as a more valuable area to be focused on?
Think about ourselves, right? The smallest issue makes it seem dire to us, and so it becomes valuable. So I've got a pain in my leg. I have really no idea what it is. I Google it. It says, oh, maybe cancer, maybe this, maybe that. And so now it creates panic, and it becomes a value to me to get it fixed or to get it looked at. And I think that's the difficulty of defining value or not defining value, because it means different for different people at different times of their life and day. And, so value-based care, unfortunately, the term is a little different, used differently. But if we focused on not calling it value, but saying we are losing in the world market because of our disproportionate use of dollars in our GDP for healthcare, and we can't compete. That's such a nebulous thing for a consumer. What do you mean? I want things from China because it's 1/10 the price of things made in the US. And then you take that and you convert it into some sort of a national pride issue, and then it takes an unintended turn. So I think there's some of that definition of what is value and why we're trying to do this. Publicizing some of the wastefulness we have. I mean, there are many studies. I think one that comes to mind is the dollars we would save from doing unnecessary X-ray exams from the emergency room. I think Harvard Medical School did something like that. Was in the billions of dollars as an estimate of unnecessarily doing an X-ray for every patient that comes into the emergency room. And I think that's a better place to start than trying to define or attempt to define what is valuable to the provider versus what's valuable to the patient, what's valuable to the family. So I think some of that reorientation needs to occur within the whole community, healthcare community.
Dr. Seth, how can specialty providers effectively manage the financial risks that are associated with value-based care? I mean, what strategies that can they use to mitigate the risks that come along with the shift into VBC?
Steve, as I've been saying all along, that data should be driving everything. And we are beginning to look at, with some of our clients, at segmenting the data by disease states. And so we are able to define through data segmentation of the disease in different phases. And I think if we broke it up into its little components, we should be able to advise or make it available to specialists to manage certain phases of the disease state, and that makes it easier to accept risk or capitated form of payments. And I think that's the only way to do this. If you don't have the data, if you don't have the integrated single source of truth with data, you can't even begin to conceptualize programs that specialists could participate or negotiate on and assume some risk. But without specialists coming into the risk profile or risk modeling and value-based care, we are not going to really make a difference. As you said, 4% of healthcare costs is driven by the PCP and their care. I mean, we are addressing a really small slice of the pie. And we need to be addressing the other 96%, and that's all based on specialty and inpatient care. So I think data can drive the change for specialists, hospitals, other inpatient type facilities, all to participating in risk-based programs if the parameters are well defined and the data is available to show them this is how we would manage risk.
Throughout this interview, we've been honing in specifically on some niche areas and getting into some really nuanced conversation. And Dr. Seth, I want to figuratively take maybe 10 steps back from the chalkboard, as it were, and ask you, when you look more widely, more broadly, more high level, what do you see as some of the emerging trends and technologies and innovation in value-based care, specifically for specialty providers? And then maybe how do you see technology playing a role in them?
I think that technology is getting ready to play a much bigger role. I think that with the advancement in artificial intelligence, in machine learning tools, and standardization of that has begun to creep more and more into technology, so that we can not only aggregate structured data, but we are able now to bring in unstructured data that requires a whole different set of technology to be converted into structural data. And that we're beginning to see that. I think those are a couple of the technology advances that we are beginning to see and including in our offerings. I think that is going to make a big difference in how data is universally available to the providers and the community. I think the payers have not invested in similar technology for the most part, so we need to make sure that they also get on the same timeline of getting advanced technologies to help them improve. I think the third thing is all the data that's available to us currently needs to become provider-facing and patient-facing, so that we can effectuate better engagement at the provider and the patient level. I think those are tools, programs that are now available. I think that's where I see greater application of tools and data to help behavior change and make the patients more aware of the total cost of care for themselves and the behaviors they are exhibiting through data as to why we think they're above average or below average. And there are so many tools available now to make apples to apples comparison. You risk adjust everything, you age adjust everything, you demographically adjust everything to sort of become the neutralizing factor. I think some of those tools and techniques that are now available, even in open data, open source languages that don't have to become IP protected and HIPAA compliant for that matter. I think those things are all becoming available, and better tools are available for cybersecurity and protecting confidential information. I think all of those trends are all converging into the same point of making data more accessible and sort of preventing abuse.
Dr. Seth, thanks so much for being with us today. Enjoyable conversation and really appreciate your thoughts and insights. It was a pleasure speaking with you.
No, thank you. Very stimulating questions. I think some of them I really had to think hard. But I think that we are reaching a point, an inflection point of how the healthcare industry needs to have a paradigm shift. And I think we are getting there. It's just not fast enough.
Our thanks to Sanjay Seth, Vice President of Customer Success at Innovaccer, for taking the time to chat with us today. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator's Future of Health podcast for more shows covering the healthcare IT topics that are shaping healthcare's future. For more information on specialty provider success in value-based care and related transition, please visit Innovaccer.com. I'm Steve Ambrose. Have a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the data platform that accelerates innovation in healthcare. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate innovation, digital transformation, and your success with population health, customer relationship management, and value-based care with Innovaccer. For more information, please visit Innovaccer.com.